Interventions with a king. Discussion and commentary based on articles from Jack, Cardiovascular Interventions.
Hi, I'm Walter Mashman from Jack, Cardiovascular Interventions. I'm here today with Professor Holger Thiele from the University of Leipzig in Germany, and we're going to discuss a paper that they've published in our journal. Professor, welcome. Thank you for being here.
Thank you for the invitation.
Tell us, please, what we know about facilitated PCI before your paper.
So, before our paper, which we are now able to publish in JACC Intervention, we knew that facilitated PCI had worse outcome, in particular in the ASCENT-4 PCI trial. And there were also some, the other major trial was the FINESSE trial, which also showed no superiority of facilitated PCI versus primary PCI. Nevertheless, there were some subgroups of patients in ASCENT-4 PCI and also in the FINESSE trial which might have benefited from the facilitated PCI approach. In particular, patients with high risk ST elevation myocardial infarction and also patients presenting very early after symptom onset.
You have a very sophisticated network for emergency transfer, and in your study you looked at STEMI in patients who presented within 3 hours. Talk to me, please, about the use of antiplatelet therapy and 2B3A agents in your trial and what we learned.
This is also a very important point, which was different from the previous trials before, which looked for facilitated PCI. In our trial, all patients were preloaded with clopidogrel, which was different, for example, for the in comparison to the ASCENT-4 PCI trial, and also different in comparison to the FINESSE trial. And then we also allowed in those patients undergoing facilitated PCI and also in those patients in the primary PCI group that they could get glycoprotein 2B3A receptor inhibitors. This was allowed in our trial.
And tell me, describe the endpoints. You used cardiac MRI to
Yes.
measure infarct size.
That's absolutely correct.
And tell me what we learned.
Yes. So we used as a surrogate endpoint, we looked for the infarct size, which we measured by cardiac MRI, which we believe is the most or the best imaging method to measure the infarct size. And also we can measure several other things like myocardial salvage and microvascular obstruction, where we know that microvascular obstruction has prognostic impact for the patients. So what we looked for in our trial is the infarct size could be reduced by the facilitated PCI approach. However, we did not find a benefit. We even found a trend towards higher infarct size and also a trend towards more microvascular obstruction in those patients getting facilitated PCI in comparison to those patients getting primary PCI.
So not too surprising. We might have expected this, but interesting and very important, particularly with a very sophisticated network of transfer. Is this the final nail in the coffin of facilitated PCI, or in whom might it still be an option?
So I think in our network, because our network was better than we anticipated before, because our transfer times were extremely short, even although the transfer distances were up to 70 kilometers or kilometers. So nevertheless, the transfer times were extremely short. And within this network, the facilitated PCI approach does not work. That's the reason why we took the thrombolysis drugs from the mobile intensive care units. And nevertheless, I still believe that there might be some room for the facilitated PCI approach. And those networks where the transfer times are much longer.
Sure.
Yeah.
Terrific. Well, I think it's critically important that the operators understand the networks available to them and the times for transfer and emergency STEMI. And this is a very important study, and I appreciate you being here with us. Thank you so much.
Thank you very much.